therapy. He is a recipient of the Distinguished Psychiatrist Award IPS Karnataka chapter, delivered the GG Memorial Oration at the University of Basel, Switzerland, received the Commonwealth Fellowship in Cultural Psychiatry, member, Board of Governors, World Association of Cultural Psychiatry, visiting professor under NIMHANS Academic Initiative Program and Department of Psychiatry, Robert Wood Johnson Medical School, New Jersey, USA. He has had more than 50 research publications and chapters in books. He's an avid bird watcher. He's a nature enthusiast, interested in visual arts, and his area of interest is cultural psychiatry. We could go on and on with one of the best doyens and teachers of psychiatry that we have known so far, especially with regard to teaching students. Some of us have not been very fortunate to be under him, but we've had a taste of what he is as a teacher. Good evening, Professor Ugram, and welcome.
Thank you.
Over to you, Professor James Tiani, sir.
Yeah, thank you. Thank you. Dear Professor Raghuram, Dr. Subhadana Pillai, Dr. Madhavan, Dr. Ramakrishnan, all the members of the organizing committee and fellow delegates. It's a pleasure. It's a real pleasure for me to be chairing a session where Professor Raghuram is a speaker. Because ever since I saw Dr. Raghuram in one of the conferences, must be years back, I always thought he is not only a psychiatrist who looks like a psychiatrist and talks like a psychiatrist. Because these days, when I say Dr. Raghuram talks like a psychiatrist, you may wonder why I am saying like that. To my mind, the psychiatrists who talk in a rather inclusive way, including various things about psychiatry, what you generally say about the biological, psychological, and social aspects all taken together in an integrated, holistic manner and try to understand human predicament. That is what I thought psychiatry is all about when I joined this branch years back. But later, I feel psychiatry is somewhere on the way took a turn, and that it has shed much of its psychosocial aspects of psychiatry, and it is mainly into biological psychiatry. So when I see Professor Raghuram, he always talks like an old-fashioned psychiatrist. That is what I like him so specially about, and I'm sure he is a person who don't need any introduction among Indian psychiatrists because he is so well known as a great orator, and his profound understanding of things about dynamic theories or psychotherapy is so well known, and nobody in this audience also, everybody would have heard him at least once. So I'm sure all of us are looking forward to the pleasure of listening, and may I ask my co-chairperson, Dr. Ramanan, to say a few words before Professor Raghuram takes over. Thank you.
Good evening, the office bearers of the Indian Psychiatric Society at the Palghat Hill, and my co-chair, Dr. James Tiani, and the guest of today's speaker, Dr. Raghuram. Today, all of us know about Raghu, and he is going to talk about COVID diaries, explorations in the psychological, psychosocial landscape. Because since the COVID, everybody had a social life, everybody had to move around, everybody had there was absolutely no restrictions. Now after the COVID, since February or March last year, we are confined to our house. There are so many self-restrictions, so many forced restrictions, so many curtailments on social activities, gatherings, everywhere. So the COVID has affected psychosocially, I mean, every human being or every animal or any being in the earth. I think Dr. Raghuram will be speaking about it. We are eagerly waiting to hear Dr. Raghuram on this topic. Over to Raghuram.
1 minute, sir. Just a minute, I'm trying to get the PowerPoint inside. And it's not showing up. Yeah. Thank you, chairpersons, for your kind words. I'm deeply touched by your remarks. It is always a pleasure to be back among friends. Whenever there is an invitation from the Kerala Psychiatric Society, I'm incapable of saying no because it gives me an opportunity to be in touch with many of my friends in Kerala, to be physically in touch, and also pursue my own other interests. As the chairperson remarked, over the past 1.5 years, this little virus, which measures just a few nanoparticles, has cast a deep influence in our personal lives. It has impacted our ways of feeling, our ways of thinking, and most importantly, our ways of responding to it. Let me start this evening on a personal note. A few days ago, our servant maid came in to collect her monthly salary, which is the usual practice for the last several months since our residential association has prevented them to come in. When she came in, she was wearing a mask, we were wearing a mask, and we kept our distance and handed over the monthly salary. A day later, the news came in from our association president and secretary that she has tested positive and she will not be allowed inside the complex. More importantly, as a primary contact, currently we are in self-quarantine for the next 2 weeks. We have been in our bubble for the last 1.5 years, but it is an enforced bubble. And even though we have been vaccinated twice all over, we have to closely monitor ourselves in these 2 weeks. That said, what bothers us and what we are concerned about is what is going to happen to the servant maid of ours. She is a migrant worker from North Karnataka who has been in Bangalore for the past 2 years. Once she is diagnosed to be positive, what is going to be her life trajectory? In her single room accommodation, how will she maintain physical distance from her family? How will she physically isolate herself from her 2 children, one of whom is just 1.5 years old? How will the family cope up with the advent of the virus when her husband has lost the job after the advent of COVID? What plays out in our servant maid is the kind of issues that everybody is facing, especially those who are socially disadvantaged. I personally feel, so with that kind of an introduction, as the chairpersons remarked, I will be orienting myself in this lecture to explore along with you the social landscape of COVID-19. Of course, COVID is a medical disease, but at the same time, it is also, I feel, a social disease. A social disease which has unleashed waves of suffering, immense waves of suffering, with attendant social fractures and economic wreckage as it plays out, for instance, with our servant. When we say that it's a social disease, look at the concept of physical distance. The ability to maintain physical distance is socially mediated. I personally feel that culturally in India, the concept of maintaining distance and concept of personal space is not very much in vogue. But beyond that, the ability to maintain physical distance is also influenced by one's economic position and constraints of housing. How will people who are living in one room or two room tenements ensure that they are remaining physically isolated? Secondly, and most importantly, the pathways to care are also socially mediated. There is an unequal distribution and availability of diagnostics, therapeutics, as also the vaccines. And lastly, the information and knowledge is also influenced by differential access by social and political networks. COVID, like many other infections, seeks out and exploits weak threads of our social fabric. And especially the COVID infection has really made our social fabric quite fragile, which has resulted in immense amount of personal suffering and at the same time, lots and lots of social suffering. What is this social suffering? Social suffering refers to modes of experience of pain and trauma, which are enacted both as an individual, at an individual as well as at a collective level, which is influenced and impacted by the psychosocial context. We can view the impact of COVID and what plays out in terms of how it affects individuals as symptoms of mental health problems. As psychiatrists, that would be our priority. Definitely, people will need and benefit from individual interventions from us. At the same time, it is imperative that we'll have to examine its wider social context, especially the attendant socially structured disadvantage which has come into play with the advent of the COVID infection. Whenever we talk about social suffering, the social suffering is buffered by social capital. I had an opportunity to address all of you in Kerala some time back during the annual conference of the South Zone in my Vishaka oration on the social capital and its importance in mental health area. Social capital essentially consists of three elements: the trust in the community, the norms that influence the behavior in the community, and the social networks that sustain the community. So basically, social capital increases an individual's embeddedness in a very supportive social milieu. It is the glue that holds us all together in a community and in a society. But sometimes that glue falls apart because of the impact of what I would like to refer to as the stigma playing out in the COVID infection. So in my talk this evening, I'll be focusing attention on the role of stigma in COVID and how we can understand and respond to it. I would feel that stigma is a social virus which is as potent as the virus that causes the illness. See, whenever we talk about stigma in relation to infection, we must remember that it has an evolutionary function through avoiding the source of infection. Yet at the same time, stigmatization involves a moral and judgmental component of devaluing the person. Stigma is also the visible tip of the iceberg of cultural systems of beliefs concerning causes and response to illnesses, which we see now currently playing out as to how people respond to the concept of vaccination, having hesitancy in vaccination, and the kind of help that they are seeking when they are afflicted with COVID. When we talk about stigma, we'll have to refer to the important contribution of Irving Goffman, who was one of the earliest writers to focus attention on it. He drew our attention to the concept of spoiled identity. He said that stigma as a process deeply discredits a person, dishonors the individual, and discounts him, and more importantly, discriminates him socially. And stigma is a product of social labeling. And we see many instances of it. There are homes under quarantine. It is called the Corona House and Corona Street, and most of the places you have big stickers in front of the house. And sometimes even an entire street is blocked because it is identified as a Corona hotspot, which restricts entry or an exit of the individuals who are in the complex. So it is a process of excluding people affected from the illness from the outside world. As one of the persons who was in such a excluded area commented, as soon as the sticker was pasted and the street in which our house was located, when it was sealed by raised barricades, people in the locality began to call our street as COVID Street. They started looking at us differently and maintained distance even after the barricade was removed and we were not detected to be positive. It was so humiliating. The stigma, more importantly, also plays out very poignantly amongst the people in the forefront of the pandemic, who are being increasingly ostracized by their neighbors, landlords, and by their own family members. And we have seen several reports in the media which really draw our attention to this. Let me outline various components of stigma. Stigma is not a unitary concept. There are different dimensions to stigma. Let us start with self-stigma. Self-stigma happens when a person with infection internalizes the negative attitudes in the community within himself. Perceived stigma refers to the belief that others have negative attitude towards oneself. Label avoidance occurs when a person chooses not to seek treatment to avoid being assigned a diagnosis of COVID. Stigma by association occurs when the effect of stigma are extended to someone linked to a person with an infection. It is also known as associative stigma. And structural stigma reflects how institutions respond to a person with infection. And public stigma is enacted when the public endorses negative stereotypes and prejudices, which is often influenced by the media. Let me, in this conversation, focus attention on the most important among all the dimensions of stigma which I referred to, which is the self-stigma, also referred to as the internalized stigma. Internalized stigma occurs when a person cognitively as well as emotionally absorbs the negative images and stereotypes and comes to believe them. As a consequence, he starts applying those beliefs on himself and acts on them, which results in significant psychological distress, which is expressed as shame and guilt, which can translate into sadness and depression over a period of time. As people with internalized stigma comment, I feel ashamed that I tested positive. What did I do to get it? Has the God punished me? I feel terribly guilty that others might get it from me. People have got to know about it. They have stopped talking to me, and I feel trapped and I feel worthless. In such a kind of an entrapped situation, it is understandable that many people who have high degrees of internalized stigma feel that ending the life might be the best option for them to really handle the situation. And we have been hearing reports of suicide among health professionals, people affected with the illness, as well as their families. What is also happening is stigma even in health, even in death. There is overwhelming hesitancy to claim the body of a person who dies due to COVID. And there is a reluctance to do the last rites. In many of the cities, the last rites are performed by volunteers and not the family members. Sometimes the family members are also expressing hesitation to collect the ashes after cremation due to fear of contamination. For example, in the state of Karnataka, is grappling with the issue of how to dispose of the ashes which is not collected by the family members. So stigma occurs when a person is infected, when a person is seeking treatment, when a person dies as a consequence of an illness too. More importantly, the marginalized communities seem to be at a greater risk for stigma. Stigma results in under-disclosure of symptoms owing to social desirability, an anticipated stigma, leading to poor treatment seeking, an increasing psychological distress, and the hidden burden of the infection. There is also the double stigma. Double stigma in those who are differentially abled and disadvantaged, and those with mental illness. When we talk about stigma in relation to COVID, I feel that the fear of the infection has overridden the risk of the disease. And it is quite easy to connect the fear with the others. There is also this phenomenon of forced empathy. Because of the paucity of social closeness due to distancing, as a consequence of social distancing, there is a significant depersonalization of relationships. As a consequence, often there is formal communication without support, which results in a feeling of force to feel or reciprocity to a person who is affected with COVID without feelings. What are the drivers of stigma? Of course, the fear of infection is the most important one. but also anticipating social ramification of disclosure, lack of awareness regarding its spread, the social judgment that can occur when a person is diagnosed to have COVID infection, blame and prejudice, and of course, the social stereotypes about the illness. But more importantly, in the current circumstance, I personally feel one of the major drivers for stigma is the fraying of trust. What we see being enacted now is fraying of trust in different domains. For example, in the domain of public trust, on institutions of governance and state and politicians, on the recommendation trust, which is influenced by scientific opinion and advice, which all of us are aware are so varied that what is deemed to be helpful at one time is dismissed as being totally unnecessary and unhelpful by scientific evidence later on. And public trust and recommendation trust has to be incorporated by the community, which I would call as a practical trust, which involves assimilation of the above two by individuals. And these are shaped by the social media to a very large extent. What personally really distresses me is stigma, and the infection is also employed as a political tool to increase and exacerbate polarization in the community, which sometimes occurs along religious lines too. And there are several instances of it in our own country. Having outlined the different dimensions of stigma, what are the factors contributing to it, and how it is enacted, and focusing attention on internalized stigma, let us now venture further as to how we can respond to stigma. How do we address internalized stigma to begin with? We can address internalized stigma by reaching out, focusing attention on the psychological distress the individual is experiencing, detecting the distress early, validating their concerns, encouraging them to share their concerns freely, especially those involving guilt and shame, identifying the sources of assistance which exist in their real life, initiating attempts to modify self-stigmatizing beliefs, and most importantly, help them to reclaim their identity beyond the illness. How do we respond to anticipatory stigma? Anticipatory stigma, we can respond by attending to the anxiety about contracting the virus, by lowering the catastrophic response that often individuals experience, and working and decreasing the phobic reaction through providing accurate information and assisting them with effective coping strategies. When we enter into the domain of enacted stigma plays out in the public domain. Enacted stigma focuses on, if we want to address enacted stigma, we have to focus on shaping knowledge and changing attitude. These strategies should emphasize, more than providing them with factual knowledge, to strategically address specific public misconception and myths about the illness and the response to the illness. The enacted stigma, one of the major aspects that influences the enacted stigma is the social media. Social media can be a source of support. which is very invaluable. People who are isolated within their home find support and succor by talking to their friends, relatives, and close family friends using the social media. At the same time, it is also a tool for surveillance. The government has introduced various apps which even physically monitor as to what is the social distance that you're maintaining with a person who is diagnosed to have COVID. And most importantly, and that is an issue of deep concern, is social media is a vector of spread of misinformation. I would call it as an occurrence of infodemic. Stigma has gone online. With regard to COVID, what we have to reconcile is there are still many unknowns about the virus, where it has originated, how it has spread, how to respond to it, which is the best treatment for it, what is going to happen after recovery from the virus. There are so many unknowns about this infection. On this background, it offers a very fertile breeding ground for misconceptions about the illness, alternative explanations about it, misconceptions and alternative explanations. We have several examples of late, which has been highlighted in the media, promoting medications which are totally useless, which in fact has sponsorship from the state saying that this particular medicine, when a medicine which is evolved by a particular person is released by the central government, whose authenticity and whose efficacy is totally unproven, we are in a deep distress. And what we are seeing in the last couple of weeks is also conspiracy theories which are coming out. How did this virus come about? Was the US involved in it? What is the intent of the Chinese government to release it from their virus, to release the virus from their labs? Why did they do it? If you look at WhatsApp, if you look at any social media, in the last 2 weeks, there is at least one conspiracy theory that is flowing out. What also happens is that the media must strive to avoid sensationalizing the infection. Verify information before communicating to the community. I feel deeply unsettled by the concept of headline stress disorder. If you see any TV channel, breaking news and headlines keep on pointing out as to how many cases are there, how many people have died, and what is all playing out. Much of it is not, much of the news can be very unsettling. But what distresses me quite a lot is the concept is what I would call as a foot in mouth disease. We must enforce a think before you speak policy for all politicians and public figures. We have had enough examples of it, even as early as in the past 1 week. What we should do is to highlight recovery-oriented narratives of people who have recovered from that. It is all said and done, there is so much of negativity about COVID, how bad it is, how severe it can be. But at the same time, people recover from the illness. A voice must be given to them as to how they cope with it, how they recovered from it. What are the factors that played up in terms of assisting them to recovery? That will give them hope. The hope will not be transmitted by saying, think positively, and conveying that positive messages will somehow address all the stigma and pain and suffering associated with the illness. We have to focus on people who have recovered and listen to their voices.
The mails takes time.
Also, I would like to emphasize that people associated with COVID care, the different sections of healthcare professionals who are battling the COVID situation, they must be involved in shaping public attitudes because they have the first-hand knowledge of how they dealt with it, how they coped with it, and how they helped people to overcome it. So these two, I feel, are important strategies to convey a positive message. If I can, sometimes I hesitate to use the word positive, convey a message that in spite of the terrors associated with the illness, there are some glimmers of hope. Another strategy which is evolving to address stigma, which is gaining currency now, is the advent of the toolkit, which unfortunately is drawing a lot of infamous political attention these days. Anti-stigma toolkit. There are several anti-stigma toolkits. There is one which I personally find it very elaborate and useful, is from King County in Seattle. These are the different components of the social media toolkit. The first one says viruses don't discriminate, and neither should we. You can interrupt stigma by sharing accurate information, show compassion and support for those mostly closely impacted. Speak up if you hear, see, or read misinformation or harassment. Coronavirus doesn't recognize race, nationality, or ethnicity. Wearing a mask does not mean that a person is ill. There is also a very interesting report in the Asian Journal of Psychiatry in May 2020 of a usage of social media kit closer home in India, handling the COVID-19 pandemic, proposing a community-based toolkit for psychosocial management and preparedness. This can come extremely useful in terms of shaping the public attitudes as well as transmitting accurate information and knowledge to the community. If we initiate these kinds of interventions, it is imperative that we also evaluate them. And I was quite impressed by this study, which came in the journal Social Science and Medicine, about stigma and misconceptions in the time of COVID-19 pandemic, a field experiment which involved people from IIT and people from Monash University in Australia. It was a field experiment which was conducted in the state of Uttar Pradesh with 2,138 participants in collaboration with IIT Kanpur, which estimated the impact of the information provided on COVID through the toolkit on the stigma index, which measured the strength of the stigma that respondents attach to people who have had COVID-19 and their families. And most importantly, they found it led to a substantial and statistically significant reduction in the value of stigma index. This is one of the intervention studies which has focused attention on the utility and efficacy of a particular kind of stigma reduction strategy. Face-to-face consultation in the field of health or mental health is going to take a long time. Telemedicine and telecounseling is here to stay. So we have to train next generation of psychiatrists and psychotherapists in conveying teletherapy effectively, ensuring the quality of care, and exploring new technologies to augment the tele-interventions, and also sensitize the people about its potential and advantages. Let me end up by outlining what could be the potential research avenues in handling stigma associated with COVID. There are several hypotheses which can be evaluated. I have listed some of them. Is the intensity of stigma related to the severity of illness of COVID? How does stigma impact the recovery process? Will stigma persist long after the infection wanes? Will marginalized people experience more stigma? Are stigmatized people more prone for mental illness? Is there a relationship between stigma and burnout among healthcare workers? What is the impact of stigma reduction strategies? Having outlined the various dimensions of stigma, various components of stigma, the importance of addressing the stigma, and the importance of various stigma reduction strategies and the need for their evaluation, let me end this lecture by saying that stigma is a multifaceted concept. It requires intersectoral interventions to address it and reduce it. I personally feel that as mental health professionals, together we can make a difference in terms of how stigma plays out and effect to reduce it effectively. Thank you so much for your patient listening. Thank you.
Chairpersons, it's over to you.
It was a very nice presentation, Dr. Dr. Ekam. We have covered almost the entire aspects of the COVID-related issues in the current scenario. I think it's very informative, and I think Dr. James P. Anthony will be having something to say about it.